Hi everybody, this is Himani Goyal from Brooklyn, New York. I'm bringing you my first voiceover educational video on cataract surgery. I share this video with you to show you my miLOOP technique and also my latest combination of MIGS procedures for patients with glaucoma. In this particular surgery, it is an iStent inject with a Cook dual blade goniotomy at the end. All right, so just keep in mind that this video is fast forwarded at 4x speed for most of the video, and we did slow it down to 2x during the miLOOP portion as well as the MIGS portion at the end. Okay, so here we go. First, we're making our paracentesis, putting in, gently bathing the entire AC with our lidocaine and epi mixture here. The goal is to not elevate the pressure while we're doing that, and then quickly our visco is going to fill up the anterior chamber until it actually starts coming out of the AC, so it's pressurized. I use my Calibri to hook the paracentesis and create the main wound with a 2.2 blade. And then here you see my little technique of placing the extra visco that I have over the cornea, so I don't need to rely on my nurses to wet the cornea with BSS. We're creating our capsular flap and then using our Utrata forceps to create a curvilinear capsular rhexis. As you can see, I'm trying to make this as circular and close to 5 millimeters as possible. And then we have our hydrodissection. I actually use a hydrodissection cannula that has a pretty curved tip, which I think is more efficient in hydrodissection because it actually follows the curvature of the nucleus. And then I'm going to go ahead and do this until I can have a freely rotating lens. Since I'm going to use a miLOOP, I did just go ahead and put in a little more visco there. I come in with the miLOOP with a soft close. I don't pull the loop so it's tightly closed. I think it is actually easier to get through the wound that way because it's not as stiff. It's a little bit more flexible. I'm using my second instrument to steady the eye, and then here we go with the miLOOP opening. I'm keeping it steady until the loop is fully deployed, passing it around. Keep in mind this is at 2x speed, so in real life I am going slower. I'm going to go ahead and try to redeploy and trying to angle it so I can get some auto rotation, but since I didn't, I closed it back. Now I'm going to go ahead and rotate this with my second instrument, and again, now deploy the loop while I'm holding it steady, and the loop is opening up horizontally until it's fully deployed, and again looping it around, and you can see the loop, the nitinol loop coming across, shining back at me, and now we have quadrants. I'm going to go ahead and come in with my phaco, and I like to do a little bit of pre-phaco setting where I clean out that fluffy cortex that fluffs up a bit with the miLOOP and create a little bit of space, taking out the visco and replacing that with BSS before I start to take out my quadrants. It gives me a little bit more room, allows more tumbling and moving of those quadrants as they're coming into the anterior chamber, and allows me to manipulate them more freely. And I'm taking out one quadrant at a time, chopping it as necessary, and as you can see, it's a pretty efficient procedure, saving all of that CDE that I would have normally used for grooving. And I don't need to do that. We're going to go ahead here with a single piece coaxial irrigation aspiration. I like to use the Intrepid IA transformer. It's made by Alcon. It's actually really neat because it's a single use, doesn't get clogged, and really efficient. I'm going to polish the capsule a little bit here, and then I can split this so that I still have my irrigation going through the main wound, but my aspirations coming through my paracentesis, and just finish polishing that capsule there. I'm filling up my capsular bag with Provisc as I get my lens ready, and since I'm using a 2.2 wound, my lens is really tight, so you do see me putting some pressure on that main wound to get the lens into the bag. So here you're going to see us moving the patient and the scope to get ready for our angle surgery, tilting the patient's eye away, head away from me, and also tilting the microscope to be at 45 degrees. So you can see I like to actually use this Volk gonio lens with a scleral fixating ring. I know that everyone kind of has their preference. And one of the things that can potentially happen when you have a scleral fixating ring is that it can collapse your Schlemm's canal. But I think with my technique, that scleral ring is actually pretty far back, and I'm not compressing it. So I'm already entered here with my eye stent, and you can see I'm zoomed in quite a lot because I like to do that, and I've injected. I'm trying to make sure that as I'm pulling this guide wire back, the stent stays in place, and I've closed the sleeve back, and I'm trying to actually just push gently on the eye stent inject to make sure that it is securely placed into the trabecular meshwork there. I'm going to try to go to the other end of my view all the way, trying to space these injects out as much as possible. And you'll see why. So I'm going to go ahead and place the next iStent inject, and again I use the same technique. Once it's there, I close the sleeve of the iStent inject, and I'm going to go ahead and just push on it gently until I've got this into a position where it's more flush with the trabecular meshwork and secure. So the reason why I'm trying to place these at the extremes of my field is because I'm going to actually go in and try to do a partial goniotomy on this patient, just to give him as much as I can in terms of pressure lowering effect with this one surgery. So I've gone ahead and just refilled my anterior chamber either with a Helon or a Provisc, whatever cohesive viscous material you like to use, and you can see I'm having a little bit of trouble getting into the main wound here. So I'm going to focus up just so that I can see. Good. I've got my Cahook dual blade now into the anterior chamber, and we're going to open up the trabecular meshwork here and then go ahead and just sweep and excise as much of the trabecular meshwork between the two stents as possible. It's pretty smooth, and then I'm going to flip my Cahook dual blade here, and again try to get this angle so that I can smoothly excise the remaining TM that's in my view. It takes me a couple of tries to kind of get the angle right, and there you go. And you can see, you know, there's already heme that's coming into the AC. Because the pressure is lower, that blood is refluxing through Schlemm's canal, and which is nice. So you know you're in the right space. And I think I've done everything that I can here. So we're going to go ahead and turn the patient's head back, get it back into view, and as soon as I'm in focus, we're going to go ahead and just irrigate and aspirate all of the cohesive viscoelastic out of the eye, and clean up that little bit of a hyphema that's formed. I'm also going to just flush off all of this visco that's on top of the cornea so I can get a more clear view and make sure that I'm good. I've made this rhexis to be pretty much my ideal size, just about 5 millimeters. It is surrounding the optic evenly all around, and we're going to just go ahead and pressurize the eye. I also do a little bit of intracameral moxifloxacin, checking my wounds to make sure that they are sealed. And if I have a leakage, I'm going to go ahead and hydrate those wounds a little bit more. I like to leave a depot of that moxie in the cornea at the main wound and in the anterior chamber. Thank you so much for watching.